It's a little bit early. I greet everyone who is already online, especially say hello to Gabriel Satmari, who's a neuroimaging neuro-ophthalmologist who has an expertise in this subject.
Good morning.
Good morning, Gabri. Sia.
Nice to see you, and looking forward to hearing the lecture.
Yes. Well, let me just start out to say that one of the goals of developing the Mind Center Institute in Budapest and having an exchange program with Hungarian students in Buffalo and now in Houston is to nurture individuals' careers and help them along. And a prime example of that would be Istvan Tomaschek. Istvan is actually a Cleveland-raised, born American Hungarian who, like many of us, including myself, went back to Hungary to the Semmelweis University, where he graduated a few years ago. And then he did, like many individuals, he did several rotations as a student here at the Dentologic Institute, where I think today we have about 5 or 6 Hungarian students here in the Institute. And the bottom line is that he was accepted to a neurology residency program at the University of Buffalo. And by the end of his 4 years, he was elected the best resident, best research, and best teacher. From there, after finishing neurology in Buffalo, he was interested in headache medicine. So he actually did a year at Dartmouth with Stu Tepper, who is one of the world's top headache specialists, trained with him for 1 year, and then came back to Buffalo to a attending position at the Dentologic Institute, which many of you know is the largest neuroscience center in the United States. So he came back, and on day 1, he already had 8 or 9 patients, new patients, and he's been very busy ever since as a major part of our Dent Headache Center, which sees about 250 patients in headache a day. So it really is a pleasure to introduce Istvan Tomaschek, who, as I've mentioned, comes from a student from Semmelweis, a resident at the University of Buffalo, a fellow at the Dartmouth Headache Center with Stu Tepper, and now attending at the Dentologic Institute, specialized in headache medicine. And as you can see, his talk today will be idiopathic intracranial hypertension, the diagnosis and treatment. Thank you very much for listening and chiming on. And here's Istvan Tomaschek.
Good morning, everyone. Thank you so much, Dr. Messer, for that very kind introduction. It's a pleasure and an honor to be speaking here today. Again, my name is Istvan Tomaschek, and I'll be speaking on idiopathic intracranial hypertension, particularly its diagnosis, workup, and treatment. I have nothing to disclose. I have no affiliations with any companies included in this presentation. Below is just a list of abbreviations which will be used throughout today's presentation. I'd like to go over the outline of the talk. I'd start by going over a brief history of idiopathic intracranial hypertension, as well as defining the disease, looking at 2 different definitions. Looking at the etiology and epidemiology, also speaking a bit on the presenting signs and symptoms, as well as physical examination findings, findings on imaging, which are interesting and pertinent, as well as the treatment, future considerations, as well as a conclusion. So Heinrich Arrhenius Quincy in 1893 actually was the father of the disease shortly after introducing lumbar puncture to medicine. He was a German internist and surgeon who utilized the lumbar puncture to assess intracranial pressures. It was shortly named pseudotumor cerebri shortly after that in 1904. And Foley had coined the term benign intracranial hypertension in 1955. However, reports in the 1980s had reported some episodes of visual loss, so benign intracranial hypertension was kind of a misnomer. Walter Dandy had created a criteria in 1937, which was later modified in 1985, and again by Dr. Deborah Friedman in 2002. The modified Dandy-Walker criteria defines idiopathic intracranial hypertension as symptoms and signs of raised intracranial pressure, including papilledema, an elevated CSF opening pressure measured in the left lateral decubitus position above 250 millimeters water. Additionally, a normal CSF constituents with normal to low protein levels should be present. No evidence of any venous sinus thrombosis on CTV or MRV. And importantly as well, no secondary cause identified on imaging, or no secondary cause of raised intracranial hypertension should be identified. Interestingly as well, papilledema doesn't necessarily need to be present. The diagnosis can still be made if papilledema is not present, but if there are other findings such as 6 cranial nerve palsy or other imaging findings on MRI, which we'll discuss in the upcoming slides. The International Headache Society has put together a classification system called the ICHD-3, the International Classification of Headache Disorders, 3rd edition, and they have essentially classified headaches related to IIH as the following. So a new headache or a significant worsening of a headache, fulfilling the criteria below. So both of the following should be present. A diagnosis of IIH should be made, as well as a elevated pressure in the CSF. Additionally, either or both of the following should be present: a headache which has developed or significantly worsened in relation to the IIH or has led to its discovery, as well as pulsatile tinnitus or papilledema. And like other classifications in the ICHD-3, it should not be better accounted for by any other ICHD or ICHD-3 diagnosis. Moving on to the etiology, in the name itself, is idiopathic, so there's no secondary cause, there's no real known cause. There should be no pathological obstruction of the ventricular system, no signs of ventral megaly or anything like that. Neurodiagnostic studies should be normal other than elevated CSF pressures. And additionally, which is important, there should be no altered mentation or focal neurological signs with this disorder. The annual incidence of IIH is 3.5 out of every 100,000. Females between the ages of 14 to 44 tend to be affected. The mean age of diagnosis is at 30. More than 90% of the patients are obese, so an elevated BMI is seen in more than 90% of these patients. And additionally, more than 90% of these patients are in the childbearing ages, so between the ages of 14 and 44 as listed above. Dr. Friedman had published a paper in Headache in 2017, which looked at the different presenting signs and symptoms in those patients with IIH. And she looked at the patients who were included in the IIH treatment trial, which I'll discuss in further slides. But it was interesting to see the different presenting signs and symptoms in these patients. It was seen that headache was in 84% of those patients, so that was the main presenting sign. Migraine composed 52% of those headaches, while probable migraine was 16%. Tension type headache was seen in 22%, and probable tension type headache in 4%. 7% of the patients could not be classified. And interesting, the mean severity of the headaches was a 6.3 out of 10. Most of them were pressure-like or throbbing, so pressure-like in 47% and throbbing in 42%. And the location varied, however, most of the headaches were in the frontal region. 68% of the patients had frontal location, while a little less than half were either ocular or nuchal, and then the rest either posterior, global, or unilateral. Additional presenting signs and symptoms were some of the associated symptoms. Photophobia is the main symptom which is seen in these patients, and is seen in 70% of the patients, while tinnitus would be seen roughly 58%, phonophobia in 52%, nausea in a little less than half, vomiting in 17%, and half of these patients had worsening headaches with routine physical activity. Photophobia without headache was seen in 5%, which was interesting as well. IIH-related symptoms include constant visual loss in 34%, and then the main symptom of transient visual obscuration was seen in 68%, while diplopia only in 22%, and dizziness in a little over half. And again, headaches without IIH symptoms was seen in 14% of these patients. I'd like to move on to the physical examination findings. And importantly, it's imperative to look at the eye with the fundoscopic exam. I'd like to go through the different grades of papilledema. Here you can see grade 1 papilledema. I'm not sure if my mouse is visible on the screen, but on the right side of the disc, you can see that there's blurred disc margins encompassing about half of the disc. The other half has a pretty clear, crisp margin. This would be considered grade 1. Grade 2 papilledema would show blurred disc margin centrally, so all the way around, without any obstruction of the vessels. Moving on to grade 3, again, there would be blurred disc margins throughout. However, on the periphery, on the outer aspect of the optic disc, you can see that there are some obstructions of the vessels where the arrowhead is pointing. Grade 4 papilledema shows, again, a blurred disc margin throughout, and then obstruction of the vessels within the optic disc. And moving on to grade 5, there's obliteration of the vessels throughout and severe papilledema. Some additional physical examination findings include a 6th nerve palsy. The abducens nerve has a pretty long course throughout the brain, and it's tethered in 2 different places at the pontomedullary junction, as well as where it enters the cavernous sinus. So one could imagine as the pressure changes within the intracranial vault, particularly increased pressure, this would cause a tethering of that of the 6th cranial nerve, leading to a 6th cranial nerve palsy as depicted in the images above. In this particular case, a left 6th nerve palsy. I'd like to move forward to speak about findings on imaging, particularly MRI. Pituitary changes can be seen, which we'll talk about in detail in the upcoming slides, as well as changes in the Meckel's cave. Optic nerve sheath enlargement is a typical finding, as well as flattening of the posterior globe. Transverse sinus stenosis can be seen, as well as cerebellar tonsillar herniation. An interesting study from Yu and his team, published in the Journal of Magnetic Resonance Imaging in 2000, looked at different pituitary morphological changes in patients with, so 23 normal subjects compared to 40 patients with a diagnosis of IIH, as well as looking at 37 patients with acute increased intracranial pressure due to trauma. These pituitary morphological changes had been categorized into 5 different categories, where category 1 or grade 1 would be normal pituitary. Grade 2 was pituitary with mild superior concavity. Grade 3 being a moderate superior concavity. Grade 4, a little bit more severe, all the way to grade 5, which was an empty cella. This study had shown that those patients with IIH had an 85% incidence of morphological changes with 80% sensitivity and 92% specificity, which is pretty good. Interestingly, an empty cell was only seen in 2.5% of these patients, which is actually pretty low. Other studies had showed higher incidence of an empty cell, but this 2.5 is a little bit low compared to other studies. And I'd also like to mention that posterior deviation of the pituitary stalk was seen in about 43% of patients. These are images from the study itself. It's not of the best quality, but one can see here that this is grade 1, a normal pituitary. Moving on to grade 2, it can be seen that the superior aspect of the pituitary gland has been indented a little bit. So this would be grade 2, mild concavity changes of the superior of the pituitary. Grade 3 is a little bit more moderate, so the indentation is a little bit more prominent, seen here. Grade 4, even more prominent, so not completely an empty cella, but getting close to that. And then grade 5 would be an empty cella. So you can see that the pituitary gland has been squashed all the way to the bottom of the cella turcica. And I wanted to show this image. This is an image from the dent, which depicts this empty cella beautifully. You can see that the pituitary gland has been completely suppressed to the bottom of the cella turcica, causing this empty cella. The proposed mechanism of these pituitary changes is that as the pressure increases, it creates a diverticulum within the arachnoid, pushing down on the superior aspect of the pituitary gland. As this pressure remains present for some time, and as the pressure increases, that diverticulum will increase in size, as depicted in the figures C and D. Additionally, as the pressure continues to increase, there's a posterior deviation of the infundibulum, which can be seen here, until the pressure completely suppresses and flattens the pituitary gland to the base of the cella turcica. Now I'd like to talk about some findings seen in the Meckel's cave. This was a study from Kamali and their team from the American Journal of Neurology in 2020, showing morphological changes in the Meckel's cave. This looked at 150 patients. 75 of the patients were diagnosed with IIH, while matched to 75 normal patients. This had essentially shown that there was acute angle changes or a bilobe Meckel's cave in those with IIH, and this had a sensitivity of 76% with a specificity of 72%. So not as good as the morphological changes seen on the pituitary gland, but still a pretty good indication that there possibly could be IIH. These are the images from the study itself. The image on the left shows normal Meckel's cave. However, figure B on the right, you can see that the right Meckel's cave is indented, almost a bilobe appearance, and this is what was seen in those patients with IIH when looking at the Meckel's cave. Additionally, some other findings seen on imaging include optic nerve sheath enlargement. Again, this is an image from the dent, which depicts this beautifully. The right optic nerve is dilated, however, the left optic nerve is even more pronounced. And the reason behind this, again, is just because of the intracranial pressure has increased, causing the CSF space to enlarge within the optic nerve sheath. This is a picture from the Journal of Neurology from 2017 depicting flattening of the posterior globe, which again, the same process where the increased pressure has been as pushing on the back of the eyeball, causing flattening of the posterior globe, which can be seen pretty dramatically here as well. Transverse sinus stenosis could also be seen in patients with IIH. This is due to either collapse of the transverse sinus due to the increase in intracranial pressure. And it's depicted well here with the left transverse sinus nearly completely collapsed. Additionally, due to the increased pressure, cerebellar tonsillar herniation can be seen, which is depicted here quite clearly. The tonsils are dipping down below the foramen magnum at least a centimeter. Additionally, a syrinx can be seen here as well. So again, due to the increased pressure, this leads the brain to go through the path of least resistance, taking it through the foramen magnum. I'd like to move on to speak about different treatment strategies for IIH. Treatment include weight loss, medications, even surgical interventions, sometimes a mixture of all three. Weight loss has been studied for IIH even back in 1974. It showed that weight loss with a low sodium diet as well as a low caloric intake with fluid restriction had a big influence on papilledema. Those patients that had lost weight on this diet had reverted their papilledema and lowered intracranial pressure. For those patients who are unable to lose weight due to an highly elevated BMI, gastric weight reduction surgery was also introduced. I wanted to talk about a few new medications that have been approved by the FDA in the recent years for weight loss, which is actually very exciting, a very exciting set of medications that can be utilized to treat IIH. I'll go through each of these one by one and talk about their mechanisms of action. So a bupropion naltrexone combination can be utilized to lower weight. This mechanism of action is not completely understood. However, it's thought to act on the hypothalamic melanocortin system to suppress appetite, as well as influence the mesolimbic reward system to decrease craving. So this particular combination is helpful in those patients who have an elevated BMI due to craving certain foods and unable to satiate those cravings. So this medication can be utilized in those types of patients. Liraglutide is a G protein linked membrane bound receptor, and this particular medication works on the glucagon-like peptide 1 receptor as an agonist. And this receptor, the GLP-1 receptor, is found throughout the brain, particularly the hypothalamus, which has appetite suppressant effects. This medication can be utilized in those patients to decrease their appetite, ultimately leading to weight loss. Orlistat is a selective inhibitor of gastric and pancreatic lipase, which ultimately inhibits hydrolysis of triglycerides, which reduces the absorption of monoacylglycerides and free fatty acids to lead to weight loss. So this medication additionally can be used to lower weight in those patients with IIH. Phentermine topiramate combination has been used as well. Phentermine is a symptomatic amine anorectic. It's an agonist of the trace amine-associated receptor sites, the TAAR1. And this releases epinephrine and norepinephrine and acts as a stimulant to help decrease appetite. Topiramate also enhances the appetite suppression and satiety by affecting multiple receptors, including calcium, sodium, GABA-A, and even carbonic anhydrase receptors. Semaglutide is, again, a glucagon-like peptide 1 receptor agonist, which improves the function of incretin, reducing energy intake and delaying gastric motility. This too ultimately leads to weight loss, which is beneficial in those patients with IIH. This medication, setmelanotide, is interesting because it acts on the human melanocortin 4 receptor as an agonist, and it has been seen that human melanocortin 4 receptor mutations cause about 6 to 8% of severe obesity. So this medication acts in a different way by working on the mutated receptor, which leads to obesity. So this is an interesting mechanism of action. I wanted to shift gears a little bit, talking about the IIH treatment trial which was published in JAMA in 2014. And this was the largest randomized controlled trial, which included 38 neuro-ophthalmology centers in the US and looked at 165 patients with diagnosed IIH. And what this study did is it randomized patients to acetazolamide with diet versus placebo with diet. The primary outcome was to look at the parametric mean deviation at 6 months, which is essentially the average difference in visual field sensitivity compared to normal. And this was used to monitor changes over time. So essentially, those patients with IIH and visual disturbances were looked at with the parametric mean deviation. And as they continued with acetazolamide and weight loss reduction, or weight loss reduction alone, it looked at the changes in those visual field sensitivities. Some secondary outcomes included change in papilledema grade, quality of life, headache disability, as well as weight at 6 months. Interestingly, acetazolamide was increased to as high as 400 or 4,000 milligrams daily in this trial. So it can be used at that high of a dose for those patients with IIH. And it showed that acetazolamide with low sodium weight loss diet in those with IIH and mild visual loss showed modest improvement in visual field function compared to those with diet alone. So this had essentially shown that both acetazolamide and weight loss are important means of treating IIH. The IIH treatment trial also showed that headache was a leading factor influencing quality of life. There was no significant correlation between headache impact test HIT6, which is a means of quantifying quality of life and impact of headache on an individual. So there's no correlation between this HIT6 test as well as the LP opening pressure at baseline or at 6 months, and no correlation between HIT6 and papilledema grade or amount of weight loss at 6 months. So this perhaps shows that lowering the CSF pressure is not all that's needed in treating headaches alone. As discussed, acetazolamide is the gold standard for medical treatment. Corticosteroids have been used in the past. However, the mechanism is not exactly known how it affects the intracranial pressure as well. But the side effects, as we all know, are there's a vast amount of side effects, and keeping someone on corticosteroids for a longer period of time is not an effective means of treatment. Furosemide has been seen to lower the intracranial pressure as well. However, this can have effects on potassium, therefore the potassium should be monitored. All in all, acetazolamide is the mainstay treatment. That's the one that should be used out of these medications. Surgical interventions can be considered as well. These are not typically first-line treatment. However, those patients that don't respond well to either weight loss or medication or a combination of both, surgical interventions can be entertained. These include subtemporal or suboccipital decompressions. These were particularly used between the 1940s and 1960s. Even optic nerve sheath fenestrations could be implemented. And essentially, this creates a window in the optic nerve sheath. There are several slits within the optic nerve sheath, allowing the CSF to leak through there and decreasing the pressure. CSF shunting is also a means of treating IIH, whether it's VP shunts or other shunting. This will decrease the amount of intracranial pressure, ultimately lowering the pressure. Venous sinus stenting has also been utilized in those patients where collapsed sinuses secondary to the increased pressure have been seen. So stenting these sinuses allows for proper outflow, reducing the intracranial pressure. So future considerations, weight loss clinic is something that is should be utilized, and we're very excited here at the Dent to be opening a weight loss clinic with Dr. Ryan Bowe. With the weight loss clinic, patients with elevated BMI, whether or not they have IH or not, will be able to seek treatment from dietitians, utilize the medications that were outlined earlier, or other means of reducing their weight. And I think it's a very important step forward for treating patients who are obese, particularly those with IIH. A lot of times we move straight to medications with patients with IIH, although weight loss is a very important part of the treatment process, and it's something that at times I think is overlooked. So we're really excited to be opening the weight loss clinic here and utilizing different tools available for that. So in conclusion, we had talked about different diagnostic criteria. We also talked about females being in their peak reproductive years with an elevated BMI were typically the patients with this diagnosis. Discussed some of the presenting signs and symptoms, including headaches, visual obscurations, tinnitus, physical examination findings, how important the fundoscopic exam is, as well as other signs such as sixth cranial nerve palsy. Findings on imaging is also very important, where someone is suspecting IIH, they could utilize MRI findings looking at morphological changes to the pituitary gland, the Meckel's cave, or other changes within the optic nerve sheath, transverse sinuses, or even posterior globe flattening would be important to assess when working up IIH. Treatment, we had discussed the different means of weight loss, medication, surgery, a combination of the three even. And we discussed future considerations. Again, we're very excited about the opportunity to work with the weight loss clinic and, and help patients, not only with IH, but also any patient with an elevated BMI to help lose that weight. So I wanted to thank you. I found this picture on the Migraine Buddy app. I found it to be relative to today's talk and the month. So I wish everyone a migraine-free holiday season. Here's a list of my references. And thank you so much. I'll be happy to answer any questions that there may be. Thank you.
Dr. Tomaschek, can I ask you a question, please?
Yes, of course.
Thank you so much. That was a wonderful, wonderful talk and a good update. My question is with weight loss. Do we have any data as far as how much weight loss patients need and what are the chances it's going to work? I think people tend to do better if we can give them goals. Is it 10 pounds, 10% of BMI?
Sure. So the study in 74 that they had done looking at weight loss, they had a goal of 6% weight loss. So I think a 6% goal is reasonable. And that's what some of the studies had shown was around 6% up to 10%.
Thank you.
Dr. Satmani, do you have any questions?
Any other questions, Dr. Satmani?
Wondering if there's a connection between undertreated or undiagnosed obstructive sleep apnea with intracranial hypertension.
For sure, I think there would be a correlation with that. Sleep apnea or untreated sleep apnea could lead to papilledema as well. So that that's something that would be assessed in the weight loss clinic, as well as incorporating the sleep team and having sleep studies done in those patients that have a high suspicion for obstructive sleep apnea. But for sure, there's a correlation between those, I would agree.
I do have a question, and maybe I missed at the very beginning. I don't know. I'm Dr. Verga. I had recently, in the last 6 months, like 3 young ladies who had all the other symptoms, and none of them had optic nerve swelling. And it was a little bit, confusing. How often do you see that they have all the other symptoms, and radiologist is all up in alarm that empty cello and all other symptoms present, and there is no optic swelling on the ophthalmology exam. And the other question is that I did use Diamox, and some patients had good effect. I see that in the studies were 1,000 milligrams even, but in your clinic, let's say, how much do you use, or do you find it helpful at all? Thank you.
Sure, great questions, thank you. To answer the first question, IH can be diagnosed even if there's not a presence of papilledema. If there's other findings such as sixth cranial nerve palsy, as well as some of the imaging findings such as posterior flattening of the posterior globe, transverse sinus stenosis, pituitary changes, the diagnosis can still be made even if there's not papilledema. That being said, that the CSF pressure should be elevated, though. That should be elevated. As far as the amount of Diamox or acetazolamide, the IH treatment trial had studied that we can go all the way up to 4,000 milligrams daily. Typically, anywhere between 1,500 to 2,000 is where people have can tolerate it well with good effects. But if it has to go further up, it can go all the way up to 4,000 as long as they can tolerate it.
Thank you.
You're welcome.
I have a question for you.
Yes.
So my husband works in the emergency room, and he wanted to know if this should ever be an inpatient workup, because several local neurologists as well as ophthalmologists are sending patients in for papilledema. So what is the, approach to that? I think a lot of these patients can be worked up as an outpatient. And how soon would you feel like imaging needs to be done? I presume these patients can have an outpatient MRI, but do you feel they should have CT scans?
So that's a great question. I think it kind of depends on the presentation. If they're presenting with visual loss, then that's a little bit more urgent and should be done on an urgent basis. So in that case, it could be diagnosed in the emergency room and worked up there. Obviously an image should be done before a lumbar puncture to make sure that there's no mass there or anything like that. That's would make an LP contraindicated. But in the emergency room, you could easily get a CT scan, do an LP, make the diagnosis, start them on acetazolamide, and then have them follow up with neurology. If the signs and symptoms aren't as severe, if there's no visual loss, if the ophthalmologist has seen them and there's no changes in their visual acuity or anything like that, then I think by all means it could be worked up as an outpatient, getting imaging and then doing the lumbar puncture and then starting them on acetazolamide or even topiramate has been helpful. Yeah.
Istvan, thank you very much.
Thank you so much for everyone's attention.
As you know, these discussions and lectures are taped, so you can go on the mind.hu website and you'll see that the lectures going back over the last few years have been taped. My only comment is the imaging perspective is that often you'll see on routine MRI, empty cella. Empty cella itself can be a normal variation, and there's different degrees of empty cella, as mentioned, but there's also enlarged empty cella. When the cella turcica, so-called Turkish saddle, is truly enlarged in its AP diameter. So there's enlarged empty cella, there's empty cella, and there's partial empty sella. So you look for secondary signs like flattening of the globe, optic nerve sheath prominence. The other problem is that you can see optic nerve sheath prominence in patients who don't have headaches and don't have idiopathic intracranial hypertension. So you have to be very cautious in interpretation of empty sella with optic nerve sheath prominence. So I'll leave that thought to individuals. And the dangerous part of it, in all fairness, is that we see transverse and sigmoid sinus stenosis and asymmetry all the time in patients who are being worked up for other disorders. And there's a tendency to place stents into the transverse or sigmoid sinus in patients with idiopathic intracranial hypertension, presumably treating a stenotic venous structure, which has nothing to do with the diagnosis of idiopathic intracranial hypertension. So you have to be cautious. If you send somebody for surgery or a stent, you better be sure that the pressures are appropriate and that you've done everything else to treat the idiopathic intracranial hypertension. So very interesting subject, more common than you would think. And although 90% are obese women, we've seen thin males with opening pressures of 400 with headaches. And the last thing is the clinical presentation, that you have to be sure that these individuals have the appropriate type of headache and not a headache once a month that you would call migrainous in nature. So we have our 2 headache specialists just walked in. Any questions about idiopathic intracranial hypertension?
It's a great lecture. Thank you.
All right, they're very excited. So again, have a nice weekend, and if not, happy holidays and Merry Christmas to everybody if we don't talk until then. And the take-home message is support your young Hungarian physicians because they become wonderful doctors. Thank you very much.
Except this one.